Hello friends, today we are going to discuss the antifungal agent, and this was also the question which was asked in DRNB critical care exam in 2019. So the question was, describe antifungal agent and role of empirical antifungal therapy. So the classification of antifungal is antibiotic. It is broadly divided into antibiotics, antimetabolites, azoles, and allylamide. So antibiotic is again divided into pollens, echinocandin, and heterocyclic benzofuran. Pollens include amphotericin B, nystatin, and the hamycin. Echinocandin include caspofungin, micafungin, and dulafungin, and heterocyclic benzofuran include griseofulin. Antimetabolite include flucytosine. Azole includes imidazole and triazole. Imidazole is again divided into tropical and systemic. Tropical include clotrimazole, iconazole, miconazole, and the oxyconazole. And systemic azoles include ketoconazole. Triazoles include fluconazole, itraconazole, voriconazole, posaconazole. Allylamine include terbinafine and the other tropical agents. Now, the risk-based empirical antifungal therapy. Numerous risk factors for invasive candidiasis have been identified. For example, high Apache score, diabetes mellitus, renal insufficiency, surgery, especially abdominal surgery, pancreatitis, the use of broad-spectrum antibiotic, parenteral nutrition, hemodialysis, mechanical ventilation, presence of central venous catheter, previous candida colonization, and therapy with the immunosuppressive agent. So risk score can be considered as an early diagnostic tool when evaluating empirical antifungal therapy in ICU at the bedside of patient with signs and symptoms consistent with invasive candidiasis. However, one challenge is that most risk factors for invasive candidiasis are also common among ICU patients without invasive candidiasis. However, the risk score usually demonstrate high negative predictive value, while their positive predictive value is usually low. So the risk factor among the various risk factor, the most commonly used risk factor is the Candida risk score. It includes total parenteral nutrition, multifocal Candida infection, severe sepsis, and post-op status. So the one score has been allotted to each point. If the Candida score is more than 2.5, it indicates high risk of fungal infection. The following factors are to be independently associated with candidiasis. That is emergency gastrointestinal and the hepatobiliary surgical procedure, ICU admission from operating theater, emergency department and from another hospital, presence of uncoated central venous catheter, total parenteral nutrition, high dose corticosteroid, prior antibiotic exposure, prior candida colonization of throat and the urine. Now let's see what is Empiricus trial is saying. Empiricus was the multi-standard double-blind randomized controlled trial conducted in 260 non-neutropenic critically ill patients with ICU-acquired sepsis, multiple candida colonization, and multiple organ failure exposed to broad-spectrum antibacterial agent that compare empirical micafungin versus placebo. The study does not support empirical antifungal therapy with micafungin in select group of intensive care patients at high risk of invasive candidiasis. Now, the next trial which was published in this context is INTENSE trial. INTENSE trial is the another RCT evaluating early antifungal therapy with micafungin versus placebo in critically ill patient with intra-abdominal infection requiring emergency surgery. This trial was unable to provide evidence that preemptive administration of echinocandin was effective in preventing invasive candidiasis in high-risk surgical intensive care unit patients with intra-abdominal infection. Driven early antifungal therapy. Theoretically, rapid non-culture based tests offer the two potential advantages in the terms of early antifungal therapy in ICU patients with suspected invasive candidiasis. So they improve overall positive predictive value for invasive candidiasis in patients with risk score suggesting invasive candidiasis. They usually show high negative predictive value on their own, thereby potentially allowing safe non-initiation and rapid discontinuation of antifungal independent of risk or result. So various non-culture based tests have been evaluated for their diagnostic performance in ICU patients. For example, serum BDG, T2 magnetic resonance candida assay, multiplex candida real-time PCR, combination of Mannan antigen, anti-Mannan IgE antibody, and candida albicans germ tube antibody. The advantage of this diagnostic tool in their quick diagnostic tool is their quick turnover time compared to the classical culture, although they could be better defined by Bayesian biomarker as they confer probability of infection and not definitive diagnosis. So for this reason, non-culture based tests should be utilized and interpreted based on pretest probability of invasive candidiasis, that is, in the combination of clinical picture and baseline risk factors. So the most studied non-culture based test for diagnosis of invasive candidiasis in critically ill patient is serum BDG. Nearly it is pan-sensitive antigen test which has shown variable sensitivity and specificity. Serum BDG display excellent negative predictive value, while its specificity and positive predictive value have been reported to improve with consecutive sampling and by increasing positive cutoff. The sensitivity of the BDG is around 70 to 80% and specificity is 60%. Another suggested way to increase positive predictive value of BDG in ICU patient with suspected candidemia is to combine serum BDG with other either specific or non-specific markers of invasive candidiasis, such as low PCT, although the related evidence is still limited to few observational study and deserve further investigation. The improved cost effectiveness of guiding early antifungal therapy by serum BDG result versus empirical therapy of critically ill patients with suspected candidemia and high candida score have been proposed by using desirability of outcome ranking analysis, although also in this case the evidence is still limited and observational. Finally, two other general considerations should be made regarding serum BDG as an early diagnostic tool for invasive candidiasis. Sensitivity of serum BDG seems to vary according to the Candida species, with lowest having been reported for Candida parapsilosis and Candida cruris. There is increasing interest in combining the use of serum BDG with peritoneal BDG in critically ill patients with suspected intra-abdominal candida, with recent and prospective multicenter study suggesting high negative predictive value in case of low concentration of both serum BDG and peritoneal BDG. Regarding molecular methods, including also T2 candida assay, the experience in the critically ill patient is still limited, but certainly their diagnostic performance in their specific population deserve further dedicated investigation. Notably, they are correctly classified as non-culture based tests. They are also enable etiological diagnosis at species level in contrast to antigen-based test. This could represent the potential advantage, although high quality evidence from well-designed RCT is needed before widespread adoption in clinical practice. Now let's see what Candicept trial is saying. In this trial, the septic adult at risk of invasive candida infection compared PDG guided antifungal strategy compared with standard treatment, and they analyzed 28-day mortality. So BDG alone was not useful to commence antifungal in patient with 24 hours of sepsis and at risk of invasive candida infection. So finally, the non-culture based test was also been studied for early antifungal discontinuation due to their high negative predictive value, with RCT suggesting a favorable effect on safety, reducing early antifungal therapy duration. Nevertheless, some caution is needed with regard to serum BDG when exploring these results to setting with high relative frequency of Candida parapsilosis and Candida auris as a causative agent of invasive candidiasis due to possible reduced sensitivity. Now about preemptive early antifungal therapy. The use of preemptive approach to antifungal therapy for invasive candidiasis in non-neutropenic ill patient is currently not supported. Considering low positive predictive value of non-culture based tests for screening purpose in this population, although it should be highlighted that high certainty evidence in this area is currently lacking. So, the final conclusion while waiting for further dedicated research in clinical practice, empirical antibiotic therapy could be considered in critically ill patients with consistent sign and symptom and probability of invasive candidiasis of more than 20 to 25% based on risk model and in critically ill patient with septic shock and multi-organ failure according to expert recommendation from ESICM and ESCMID guidance. Thank you guys.